There are three operative phases. One is preoperative. This starts when you decide to make your decision to have surgery, all the way up until they take you into the operating room. Intraoperative is the time when they are in the actual operating room, all the way until they are finished with your operation and you go to the post-anesthesia care unit. Postoperative is the period following surgery. This could be just for a couple of hours where you are post-operative, all the way to up to 6 weeks where you're having therapy and rehabilitation. So it just varies from person to person. When you decide to have surgery, there's going to be a full assessment done of you. You're going to have your medical record that is going to be provided to the surgery team, including all of your information, what type of surgery you're going to have. They will do a full assessment to make sure that you're physically able to do the surgery. So you may have a surgery where you have to have an EKG performed, or they might do some respiratory tests, some pulmonary function tests on you to ensure that your lungs or your heart is able to withstand surgery. Now, there is something that anesthesiologists will usually ask you before you have surgery. They'll say, have you ever had any reactions to anesthesia? What they're asking that for is for something called malignant hypothermia. Malignant hypothermia is a severe reaction to certain anesthetic medications. So it can be life-threatening for them. Now, that's not going to stop you from ever having surgery again. What they'll do in the future is just give you some medications prophylactically and monitor you a little closer during that anesthesia time. They're going to look for any allergies, make sure if you have food allergies, medication allergies, if you're allergic maybe to even latex, that might influence some of the things that they do to you during your procedure. If you're a smoker, a lot of physicians do not like to perform surgery on people who smoke just because it can delay and cause complications with their wound healing. So if you have an elective surgery, you may have a surgeon that says they will not operate on anyone until they are nicotine free. So they can even do blood tests to see if there's any nicotine in your body, and they will cancel your surgery if you've been smoking. Now, of course, this doesn't involve someone who has an emergency surgery. We just can't help that. But for elective procedures is when we're concerned about this one. Usually prior to surgery day, they will want to do some blood work, most commonly like a CBC to check your hemoglobin, hematocrit to check your platelets. Usually that's completed prior to your surgery day. One test they will want to do on you on surgical day will be a pregnancy test if you're a female and in the childbearing age. We just don't want to operate on anyone who may be pregnant and do not know they are. The client will need to have completed informed consent, making sure they understand the risks and benefits involved in the surgery. This should be presented to them from the surgeon themselves. They have to be aware of what is going to happen to them during the surgery and what the expected outcome will be. Also, the nurse can provide some preoperative education to them. This is going to be things like, where are you going to go when you have surgery? What time do you need to arrive? How long do we expect your surgery to last? Where will your driver wait for you? What do you need to do to prepare for surgery? Do you need to take a certain shower, like a chlorhexidine bath, before you come? Do they want you to do a bowel prep? And then they need to let you know what's going to happen after surgery. Are you going to stay in the PACU for a couple of hours and then go home? Or are they going to take you up to the ICU? Or are you going to go inpatient? And then any post-op care that they need to know, like if they have to take care of trains, if they're going to have to change their bandages once they go home. That is all very important. They know that ahead of time. The scrub nurse is the person that hands the instruments to the doctor. They're the ones that make sure the instruments are sterile and ready to use. Now, Commonly, we have certified surgical technologists, or what we call a scrub tech. These are people that have taken a certification in being able to do this, and so they stand right there by the surgeon and help them in any way that they need it by providing tools, providing sponges, different things like that to them. They're also responsible, they and the circulating nurse will get together and count multiple times to make sure they have all of the towels out of the patient, all of the instruments, all of the needles, everything is accounted for. There will also be an anesthesiologist at the surgery. Now, it can be a regular anesthesiologist or what we call a CRNA, which is a certified registered nurse anesthetist. So this is an RN that has gone on and had additional training in anesthesia. Depending on what type of surgery you're going to have is going to depend on what type of anesthesia they're going to give. So we could give like a local anesthesia. So if you've ever had like stitches, that's what you got, was a local anesthesia, where they just numb that area around the site, just so they don't experience pain. Regional anesthesia is just going to give us loss of feeling in one area. So if you've had maybe an epidural, that is a regional anesthesia. If you've had a nerve block, that's regional anesthesia. It's just going to take away the feeling in that one area. Now, general anesthesia, this is when we use drugs and or inhalants to depress the central nervous system. So we're getting to them to the point that they might not be able to breathe on their own. We might have to put a tube down their throat and breathe for them. They are totally unconscious and unaware of anything happening to them during this time. Another type of anesthesia that we use is conscious sedation. This is something that keeps the patient calm and they're still alert enough that they can follow directions, but they're not going to feel that pain or anxiety. So common time we use this is going to be if someone's having a colonoscopy. If you're having, for example, when I broke my wrist, they took me into the room in the ER and they gave me conscious anesthesia while they set it and while they wrapped it up. The circulating nurse is another role in the surgical suite. They take care of you before, during, and after your surgery. So they're the ones that are with you during pre-op. They're making sure all the forms are filled out. Everybody has their consents. They're probably putting the IV in the patient. Then they go with you back into surgery. They're going to document everything that happens. They also are going to help that surgical nurse or the scrub tech to count the sponges, instruments, anything to make sure they haven't left any tools inside of the client there. Now, in the post-operative stage, this is going to be after we come out of the surgery room and we're in what we call the PACU, the post-anesthesia recovery room. The most important things that we want to do is monitor their breathing, especially if they've had general anesthesia. The way to get rid of some of those gases that we use for anesthesia is through breathing. So we're going to listen to their breath sounds and make sure they have a good respiratory rate. Make sure they're breathing evenly. Make sure that we're checking their pulse ox to make sure they're getting enough oxygenation. We'll want them to take deep breaths. After they get into their room, if they're staying at the hospital, we're going to give them what's called an incentive spirometer. And this is where the little plastic machine where they have to kind of breathe into it. We want to remind them to cough. We want to remind them to take deep breaths. We want to remind them to make frequent position turns as they're able to try to get rid of some of that anesthesia that's in their lungs. We worry also about the cardiovascular system. We want to make sure they have pulses on all extremities. They may have sequential devices on their legs to help to prevent DVTs, deep vein thrombosis. We want to check that surgical site to make sure the bandage is intact, that it's not bleeding. We want to monitor their vital signs and a mental status. Now, I mentioned the surgical dressings. Most surgeons are going to want to make sure that those dressings are left in place for at least 24 hours. Now, that patient may have some drains somewhere on them to kind of remove some of the blood and fluids from around the surgical site. We need to monitor those as well. We want them also to be laying in the best position that is going to provide them comfort. So, for example, if we have somebody who's had abdominal surgery, we don't want them lying flat on their back because that's going to put too much tension on that suture line and could cause it to come apart. What we want for them instead is to be sitting up just a little bit to decrease some of that tension. So there's a lot of risk factors to having surgery. Again, they may go to the floor, they may go to the ICU, they may go to home following their surgery once they've been cleared stable from the PACU. Post-surgery, they are going to have some things like nausea and vomiting. But some of the things that we're really concerned about with them are their age. People that are older, they tend to have more comorbid conditions, and so it might be a little bit more difficult for them to have surgery. We like for them to have a good nutrition status so that they will heal well. If we've got someone who has not eaten very much and has been losing weight, it's going to take a little bit longer for them to heal. People that are overweight, there's a lot more complications they can have with their respiratory system, with healing, and again, any infections. If you are sick and have had an infection, we probably don't want to operate on you. So some things that you'll see outside of the surgery, usually post-surgery, people will have nausea and vomiting. That's to be expected. We might see a change in their mental status, so you might need to remind them frequently, you just came out of surgery, you're doing fine. I mentioned a thromboembolus or a pulmonary embolus. This is when we get like a blood clot in our extremities from not moving, and it can travel to your lungs and cause a pulmonary embolism. They might have low blood pressure, low blood volume. Maybe they've lost a lot of blood during the surgery or previous to the surgery. They can have atelectasis. And what atelectasis is, the surfactant is gone from the lungs, usually as a result of some of the anesthesia that they've been breathing. And it gets down into the alveoli and it causes those to collapse. And so if the alveoli are collapsed, we're not getting good air exchange like we should. They call that atelectasis. Wounds can get infected. Post-surgical infections, I've seen it happen. Again, people with risks are maybe those that are smokers. It can also be from something that occurred during surgery. We try to keep that environment as sterile as possible, but occasionally things do happen and you could have an infection from there. Wound dehiscence, I'm going to talk about that in a little bit later. An ileus is where the intestines do not start moving again and they kind of get stuck and sluggish. So this person won't be able to eat. They'll start to get distended and bloated. So what we'll do is we'll keep them NPO. We'll probably give them IV fluids, and usually they'll get an NG tube to kind of decrease some of that pressure that's building up, some of the gas that's building up. And then once that bowel returns to moving again, and sometimes it might take a few days, then we're able to pull the NG tube and we're able to let them start eating slowly. Because of the medications used, those might cause some problems with their kidneys. And so we really want to monitor if they've got good kidney output post-surgery as well. So I talked about dehiscence. Dehiscence is the separation of wound edges. Usually they're going to happen in an abdominal wound is where we see it the most. Maybe there's some kind of infection within there. Maybe they're on steroids, maybe they've been smoking, maybe they just have weak muscles. So what's going to happen is that wound is going to pop open for them. Sometimes you might have a physician who might go back in there and try to sew it up, but usually once dehiscence or evisceration occurs, they will leave the wound open and let it heal from the inside out. Evisceration is the same thing. That wound has popped, and they usually will hear that pop, and then their internal organs begin to come through that wound where it has opened. This is an emergency, and they will get a trip back to the OR. Managing pain is very important in that post-op period. we give them opioids usually as they come out of surgery, as they're in the PACU. But once they go to the floor, they may need they'll continue to still need the pain medication. So if they're alert enough, we can give them what we call a PCA, or a patient-controlled analgesic unit. This will give them a dose of medicine consistently across the board. It's going to go out. But then let's say they, for some reason, are having more pain. They kind of, maybe they get up and move to the bathroom and they come back and they're hurting real bad. They can push the button on their PCA and it will give them a bolus dose of pain medication. They have to be alert enough to push that button, though. No one can push it for them. And after surgery, we still want to keep our clients safe. So think about the fact that they probably are on pain medications, are not moving as much as they're used to. So that puts them at a high risk for falls. They can also aspirate. Aspiration is when food or liquids go into their airway instead of the esophagus. This can happen during surgery. It can happen when they're taking those first few drinks after surgery. So we want to make sure before we start giving them fluids that they're awake enough that they can drink those. They might be confused when they come out of surgery. So you might need to, again, remind them where they are and where surgery was complete, or that their surgery is complete. This may last even for a few days where they're kind of foggy in the head.